webinar hosted by the Convenient Care Association on colorectal cancer. I am pleased to introduce Dr. Laura Bruni. She is an assistant professor at the University of Texas Health Science School of Nursing. She is a family nurse practitioner and has been for 15 years, and she works currently in a nurse-managed health center. Dr. Bruni?
Hello, everyone, and thank you for participating in today's webinar. My name is Dr. Laura Bruni, and I'll be your speaker today. And this webinar, as you can see, is on colorectal cancer. And we're going to touch on the etiology and prevalence, available screening options, and patient engagement. As you heard in the introduction, I've been a family nurse practitioner for the last 15 years. I've had the opportunity to recommend screening to hundreds of patients, and quite honestly, not always had the best success at convincing patients of the importance for screening. And talking with my colleagues, I realized I'm not alone in this observation. In fact, a few years ago when our nurse-managed clinic sought accreditation as a patient-centered medical home, I had to really scrutinize our process of health maintenance screening as it relates to colorectal screening. Follow-through on recommended screening became one of our main objectives to improving practice. So there's many reasons why patients resist to having their colon checked, many of which relate to negative things they may have heard about colonoscopies in the preparation leading up to the study. But today there are options to testing, and some of these options may fit your individual patient better than across-the-board invasive testing. We will discuss each of these options today in the program. So here are some of the objectives for us. In order to advise your patients appropriately, patients must understand the importance of screening, what it does and does not provide, along with expected outcomes. When we begin our discussion with vital statistics, hopefully we'll create a sense of urgency for you when it comes to screening. Following our facts on colorectal cancer, I will provide an overview of anatomy and physiology, which will then lead us into the screening options available today. Finally, we will touch on the importance of screening and how to engage your patients in a discussion. While generalized guidelines are important, clearly individualizing patient recommendations meets with higher success rates and improved patient satisfaction. In order to provide this service, however, you must not only know the test, but you must also know your patient. Now, a picture can sometimes be worth 1,000 words. Each year, the American Cancer Society publishes statistics on the most common forms of cancer. And from this particular slide, I believe one of the most surprising facts is that colorectal cancer is the second leading cause of cancer-related death in the U.S. 50 has always been recognized as a magic number, as I like to call it, since that is when we begin screening for colorectal cancer. Now, there are cases of colorectal cancer before the age of 50. But approximately 90% of colorectal cancer occurs after the age of 50, and 93% of deaths occurring from those in over 50. For those individuals who have a first-degree relative with cancer, risk of cancer is increased, but generally speaking, average risks are approximately 1 out of 20. The American Cancer Society estimates that for 2015, there will be over 93,000 new cases of colon cancer, and almost 40,000 new cases of rectal cancer. And these numbers are only expected to increase as the population ages. So here's a few facts on colorectal cancer. Consider first that every adult over the age of 50, if they were screened adequately, it's estimated that 80% of deaths from colorectal cancer could be avoided. That means that in 2014, there were approximately 50,000 preventable deaths from colorectal cancer, with 26,000 being men and 24,000 being women. And in addition to the psychological burden of the disease and possible death is a rising economic burden. The financial impact of colorectal cancer is staggering. Estimated cost of care is up to $22 billion annually, with up to $70.9 million in lost wages. These numbers simply add to our already overburdened healthcare system as we deal with the aging and chronically ill population. But the take-home message from all of these facts and figures is the last bullet on this slide. CRC is often asymptomatic, and routine screening will prevent most cases of colorectal cancer if we can catch it before it advances. Now, we hear a lot in the information in the media, online and in print, about all types of cancer. It sometimes seems like information overload with the various fundraisers and awareness campaigns for breast, prostate, and cervical cancer. And think about lung cancer. It has received a tremendous amount of publicity with smoking cessation campaigns and the limitation of acceptable smoking years as compared to what it was a decade ago. In fact, many of our pay-for-performance guidelines, those that are initiated by our clinics, mandate that we include education about smoking in the primary care visit. So as you can see in this visual depiction, colorectal cancer is second only to lung cancer in overall death. If you take that fact, keeping in mind that appropriate screening in those aged 50 and above can prevent 80% of deaths, you now understand why screening becomes so vitally important. Add to this the fact that most adults have a visit with a PCP this year, whether it's for an annual exam or a sick visit, and you begin to see the potential prevention opportunities available to our primary care providers and practices. But despite our best efforts, and some would argue that we're not putting forth our best effort, 1 out of 3 adults are still not being screened. Studies suggest that primary care providers fall short of screening recommendations for a variety of reasons, and some of these include forgetfulness, time constraints, logistics, patient discomfort, or even a simple lack of knowledge regarding the screening options. So let's compare colorectal screening to some of the other cancers that undergo routine screening. Take a look at this slide for just a moment. Note that rates of screening for colorectal cancer fall well below rates for Pap tests as a screen for cervical cancer and mammograms to screen for breast cancer in either men or women. So is it that providers are still not recommending colorectal screening, or that the patients are not following through? This is a question that deserves some reflection. We know providers report barriers to screening. I just listed a few of those above. But we also know that providers often wait until a patient has symptoms, such as rectal bleeding or blood in the stool, bowel changes, along with fatigue, before they're referred for a colonoscopy. But even with a referral, patients may not follow through due to additional personal concerns with testing, often citing things such as aversion to bowel preparations, fear of pain, or even embarrassment. And in a discussion about primary prevention, risk factors always have a place. Research has identified a number of risk factors associated with the development of colorectal cancer. These may include things like activity level. Those who are more active have a lower risk of colorectal cancer versus those who are less active. People who are overweight have a higher chance of colorectal cancer and simultaneously have increased risk of poor outcomes from the disease. Smokers have a higher risk of colorectal cancer, which gives us yet another reason to take every opportunity to advise smoking cessation. People who drink more than 2 alcoholic beverages daily, or those with insulin resistance or type 2 diabetes, also have an increased risk. Now, this sounds like a typical primary care patient, does it not? Risk factors include diet, family history, and certain high-risk conditions. Diet plays a role in the development of colorectal cancer. Healthy recommendations include avoiding a diet high in red meat, such as beef, pork, or lamb, or processed meat, such as hot dogs, bacon, or cold cuts. And who doesn't eat bacon, hot dogs, or cold cuts? But also increasing the intake of fresh fruits and vegetables. There are certain hereditary conditions that may predispose families towards colorectal cancer, and those need to be assessed in the family medical history. And finally, not to be confused with IBS, or irritable bowel syndrome, is inflammatory bowel disease, things like Crohn's disease and ulcerative colitis, which increase one's risk for colorectal cancer. In these individuals, the recommendations for screening differs from those of the general population. So let's look at some anatomy and physiology. This will help us to understand the disease just a little bit better. Recall that the large intestine is simply a tube whose primary function is to absorb salt and water from food and serve as a pathway for waste products. Large intestine consists of the cecum, the ascending colon, which is over on the right side, the transverse colon, and the descending colon on the left side. Altogether, the tube is approximately 5 feet long and terminates in the rectum, which really accounts for about the last 6 inches. Colorectal cancer is classified as either belonging to the colon or the rectum or both. Now, cancer itself is defined as unregulated cell growth of mutated cells. The original cellular change takes place when DNA is altered in response to environmental, genetic, or other triggers. Mutated cells then invade healthy tissue, causing alterations in function and subsequently rendering the tissue ineffective. Neoplasms can be benign or malignant. In the colon, 95% of malignant tumors or precancerous growths known as polyps are adenocarcinomas, which emerge from the epithelial layer and the glands that make the mucus to lubricate the colon. A second type of polyp, referred to as hyperplastic, is a low-risk neoplasm that generally does not go on to develop into cancer. However, many providers will remove these polyps, still considering them a risk. Other types of tumors within the GI tract may include carcinoid tumors, which are hormone-producing tumors, and gastrointestinal stromal tumors. But for the purposes of our discussion in colorectal cancer, most of these tumors are adenocarcinomas, which begin as a single polyp or a precancerous lesion. Polyps, by definition, are a precancerous lesion typically removed during a colonoscopy. If, however, the polyp is allowed to progress, it may develop into a malignant lesion. The higher the number, the more advanced the stage of cancer. Stages are numbered 1 through 4, with 0 as a polyp limited to the mucosa or just inside the muscularis layer. As the tumor extends deeper within the tissue, the stage advances. And by stage 3, regional lymph nodes have become involved, and stage 4 occurs when the cancer metastasizes to different organs. This slide once again demonstrates the importance of screening. Early detection and treatment will improve outcomes. Regular screening helps to detect cancer at earlier stages. Therefore, the more regular the screening, according to the published guidelines, the higher the probability of detecting cancer in its earlier stages. What you see on this slide is that colorectal cancer is treatable. Waiting encourages poor outcomes. Stage 1 offers a 94% probability of survival, while stage 4 may only provide an 11% chance of survival. These numbers are based on 5-year survival rate. Now, as you already know, cancer that is found in later stages will generally involve metastasis to different organs, and colorectal cancer is no different. As colorectal cancer advances, metastases, often to the liver, will occur. So here's a few prognostic indicators. These will help to give you an idea of prognosis, such as, really, how bad is this? For example, when staging the cancer, the more lymph nodes involved, the more poor the prognosis. And the same holds true for tumor spread. Metastases stage the cancer higher and create a more complex plan of treatment. Remember, stage 4 only holds an 11% survival rate, and the most common site is the liver. And finally, if the pathology report is returned with poor differentiation, this is recognized as a poor prognostic indicator. Although many times colorectal cancer may be asymptomatic, this slide will provide you with some of the common symptoms we may see in clinical practice, and they're generally dependent upon where the tumor is located. Symptoms such as fatigue, anemia, and palpitations may indicate a right-sided tumor, while left-sided tumors may show up as abdominal cramping or obstruction. Terminal tumors, rectosigmoid, will narrow the caliber of the stool while causing hematochezia and tenesmus. So how do we go about screening? Does it always have to be a colonoscopy? And how often do I need it? These are a few of the questions that patients will ask. I sometimes have patients tell me that they get their colonoscopy every year, and I know this can't be true. After all, that is not the recommendation, and who would go through that every year? Take a look at the categories on this slide, and you will see that there are both non-invasive and invasive tests, and we'll take a moment to discuss each of these individually. The key with screening is you need to understand what the test does and does not do while considering your patient's preferences. It won't help your patient to insist upon a colonoscopy if there is no way they will submit to a colonoscopy. It would actually be better to have them undergo one of the other methods and have some information as opposed to no information. Non-invasive testing generally requires no bowel preparation and may be done in the privacy of the home, which appeals to some of our patients. However, non-invasive screening options are effective at detecting cancer, but perhaps not as good at detecting polyps unless they are in an advanced stage. But invasive testing may be effective at detecting both. Remember, those polyps are precancerous lesions. So fecal occult blood testing or fecal immunochemical test, the FOBT and the FIT test. These can occur in the office during a routine visit, such as during an annual wellness exam, or patients can do these at home and send them to a laboratory for evaluation. These are low-cost tests and require no bowel preparation. It's best if you can utilize multiple stool specimens, and the recommendation is typically 3 separate samples. FOBT can miss most polyps, and there is a potential for false positives, particularly if you've consumed non-steroidal anti-inflammatories or red meat within 3 days of the test. So those things need to be communicated to your patient. If you consume vitamin C or citrus juices, on the other hand, you may get a false negative. But again, the test is inexpensive and will detect cancer with a 74% sensitivity. It's easy to do, and the results are available within seconds if it's done within the office. DNA testing, or the Cologuard test. DNA testing of stool is not a new concept, but newer methods have improved upon the original test, which was discontinued in 2008. These tests are excellent at detecting adenomatous lesions and better than the FOBT or the FIT at detecting precancerous lesions. Cologuard is the trade name of this test, and as with the FOBT FIT test, it's done in the privacy of the home. Patients are provided collection instructions along with all the tools needed to perform the test. The stool DNA has about a 92% sensitivity in detecting cancers as compared to FIT with a 74%. For lesions, Cologuard is 42% sensitive, while FIT testing is only 24%. Cologuard is recommended about every 3 years, provided routine colonoscopies are being performed in the proper intervals. This test is covered by most insurance, including Medicare. And for the patient who refuses a colonoscopy, this is an excellent alternative. Flexible sigmoidoscopy is an invasive test, and it will require some bowel preparation, generally in the form of enemas. Bowel cleaning is one of the most commonly reported barriers patients report when they start to consider screening for colorectal cancer. With this test, a slender tube, smaller than the one used in a colonoscopy, about 2 feet long, and allows for visual inspection of the rectum and lower third of the colon, is inserted. The test really cannot visualize the transverse colon or the right side, so if a polyp is found during this test, the patient will then need to undergo a full colonoscopy so that the entire test can be examined. This really is a limitation of the study, and some would argue if you're going to undergo a bowel prep and there's a possibility that a full colonoscopy will be needed anyway, why not undergo the full test and be done with it? Sigmoidoscopies are recommended about every 5 years, but if colonoscopies are done, this test really is not necessary. The colonoscopy, it is the gold standard for detecting precancerous and cancerous lesions, but really many patients refuse this screen. Patients report a number of barriers to the test, which include bowel preparation, cost, lack of control, and embarrassment. But despite the high sensitivity and specificity, colonoscopies carry a higher risk of bowel perforation than any of the other tests. The bowel preparation for this test, as compared to the sigmoidoscopy, is a more thorough cleaning of the entire colon. So in addition to the bowel prep, it also requires a period of time with only clear liquids. This is one of the most sensitive methods for detecting cancer or polyps, and any polyps identified can be removed during the procedure. If the test is determined to be normal, Follow-up is not necessary for 10 years, and for many patients, that is a bonus. CT colonography, or virtual colonography, uses imaging procedures to produce images of the colon. First, the colon must be thoroughly cleansed with a bowel preparation. The output is a 3D image of the colon, which allows for identification of cancer or polyps. The test does not require that your patient be sedated, and that can be really important when considering the very frail or ill patients who may require testing. And it only takes about 10 to 15 minutes to complete. But if a polyp 5 millimeters or larger is detected, the patient then again will need to be prepared for a full colonoscopy. And finally, there's the double contrast barium enema. Although there's utility of this procedure for various gastrointestinal abnormalities, with the availability of colonoscopies and now virtual colonoscopies, the overall usefulness of this test has diminished, and the side effects of this screening are possible constipation, inflammation from the barium, and even colonic rupture. After a thorough bowel prep, the procedure includes administration of barium into the colon, followed by air, which then inflates the colon, and then x-rays are taken, which help with the visualization. As with some of the other tests, if detection of a polyp means that the patient will then need to undergo a full colonoscopy so that the entire colon can be examined. So this slide will sum up some of the sensitivity and specificity we've just discussed. As you can see, all of the tests are sensitive for cancer, but the non-invasive tests are generally not as sensitive for polyps, although the DNA stool test has a higher sensitivity for it than the FIT testing. Now this slide will provide a good summary of the test and hopefully provide you with a quick reference tool when considering what is best for your patient. Some important points to keep in mind will be cost of the test, ability of the patient to perform the test, and by that I mean read and understand the instructions, tolerate the sedation, or tolerate the bowel cleansing. Understand the risks, the benefits, and the time required between screenings. One other consideration is your patient's medical history. You need to consider whether there is a presence of genetic or chronic conditions that may place them in a high-risk category, which will affect their screening frequency. In these cases, it's going to be best to refer them to a specialist so that they can establish an appropriate screening protocol for a patient with special needs. But despite all our best efforts, patients are still not getting screened. So how do we go about getting our patients to understand the importance of screening and motivating them to follow through with recommendations? Research as to how patients make decisions really supports engaging patients and strongly encouraging them to be part of the decision process. In order to improve patient engagement, there's several methods you can try, and these include active listening, shared decision-making, enhancing patient literacy, and acknowledging cultural diversity. Active listening occurs when the listener provides cues to the speaker. For example, nodding the head, asking questions to clarify, or restating what the patient has said. Support shared decision-making by providing a limited number of choices to the patient and offer them the risks and the benefits. Act as a partner in the decision-making process and support their decision. However, you have to be careful not to provide too many choices, otherwise patients may become unable to make a decision due to becoming overwhelmed by information. Provide enough information so that they clearly understand the risk of inaction, and recognize that certain cultural distinctions exist and will definitely impact a personal medical decision. At the end of the day, you need to feel confident that you did your job in motivating your patient to action. So the strategies I've listed here should help to enhance your success in compliance with recommended screening. In the case of colorectal cancer, screening is available almost universally, whether it be in the office or the home or a colonoscopy. There are a few reasons that exist for screening noncompliance. Since patients will be more apt to screen if you first educate them as to the importance of the screening, give them real information surrounding risks and benefits of no screening, then offer a choice in screening mechanisms. Although most, if not all, providers would prefer our patients get a colonoscopy, This simply doesn't happen for many of them, for whatever the reason. But don't let your work stop there. Provide an acceptable alternative, and finally support the decision that the patient makes, and the screening is much more likely to take place. Now, take a step back and look at your own practice. What are your rates of success at screening? If you're not seeing the results you expect, you may need to look at your current processes and identify where improvements can be made. For example, if you work in a large practice, it may help if the practice develops a policy that everyone follows. Patient reminders or clinical quality messages within the electronic record that notify you when a patient is overdue for screening are always helpful. But the key is to develop a process, follow up, measure your outcomes, and make changes based upon the results. Quality improvement is a work in progress. Many of us work in busy practices, and while screening may not be the most important topic for this patient at this moment, if we don't discuss it with the patient, who will? If you're one of those people who likes to follow a guideline, these step-by-step instructions will help to improve your screening success and will also help to guide you through discussions in the clinic. Clear communication is going to be a key component in these discussions. So first, you want to discuss what the needs are and why they need to get screened. These screenings will help to detect cancer early and improve their outcomes. Give them basic information on the appropriate methods of screening and help them to make a decision. Discuss the risks and benefits and determine the best method and assist the patient in selecting the screening option. Answer any and all questions and schedule the procedure, and please be sure to provide the tools they will need to complete the screening, and follow up and be persistent in all your recommendations. So now that we've done everything right and our patient's finally gotten their screening, the worst case scenario happens. There's a diagnosis of cancer. What now? What happens next? As their primary care provider, you need to be prepared to discuss their concerns, reassure them appropriately, and simply offer your support. The process begins with routine screening. If there's a suspicious polyp or a lesion, it needs to be removed and pathology reports. Discuss your results openly with the patient and talk potential outcomes out with them. These will depend upon the stage of the disease. Include family members when they are available, as this will often help to support the patient. And know that the patient is going to be referred to oncology for a full plan of care. The treatment will depend upon the stage of the cancer, and excision versus anastomosis may subsequently occur due to the size and degree of tissue invasion. The more advanced the cancer, the more complex the treatment regimen will be. In general, colorectal cancer, if identified before metastasis, has a fairly good prognosis. For some of these patients, surgery may include a temporary ostomy, which may later be converted to an anastomosis of tissue once the bowel has sustained rest and rehab has occurred. Chemotherapy and radiation will be directed by the oncologist. If an ostomy is in the plan of care, a patient may expect ostomies to be located dependent upon where the cancer occurs. Oftentimes, these are temporary diversions until the two sections of colon can be anastomosed. There are, however, unfortunately, occasions when an ostomy is permanent, but that will be determined by the oncologist. So in summary, take-home messages for everyone today. Colorectal cancer is preventable, provided early screening occurs. Colorectal cancer is treatable, provided there is early identification. Healthy lifestyles contribute to all healthy behaviors, and colorectal cancer is not singled out in this regard. It contributes to improved outcomes, but it's estimated that lifestyle choices may prevent up to 75% of colorectal cancer. Discuss screening options with your patient, and through this shared decision-making, select the best option for that particular patient, and stress the importance of screening with each and every visit. And to end our discussion on a humorous note, remember, this is how many of your patients feel. So give them other options, and you will find that your screening rates will increase. Thank you for your time today. I hope you found this information useful to your practice.
Thank you, Dr. Rooney. That was very informative, and thank you all for attending. If you have any questions, please feel free to email the Convenient Care Association. You can reach out to Sarah Rosenberg at srosenberg, R-O-S-E-N-B-E-R-G, at ccaclinics.org, and we'll facilitate getting an answer for you. Thank you again for attending.